So welcome everybody. Thank you for joining us. I am Kendra Nielsen Miles. I am the president or the founder and CEO and executive director of EDS Wellness, and I help the Metro DC EDS and HSD support group with their virtual meetings. As most of you know, I know many of the people within the group over the years of the work that I've done, as well as the work I've done with the group. So welcome, and we're happy to have Dr. Kogan with us. So Dr. Kogan is a professor of medicine, the medical director for the GW Center for Integrative Medicine, and the associate director of the Geriatrics Fellowship Program at the George Washington University. Born in Moscow, Dr. Kogan immigrated with his family in his teens, first to Israel and then to the United States, where he obtained his medical degree from the Drexel University College of Medicine in Philadelphia, Pennsylvania. He has taken a special interest in integrative and functional medicine and treating patients from a whole body perspective. Excuse me. This approach has been tremendously helpful to many patients' improvements in quality of life. Dr. Kogan works with chronic illness patients, including a number of people with EDS and HSD, as well as other multi-system issues, and has a special interest in geriatrics, healthy aging, and Alzheimer's. He is the author of Medical Marijuana, Dr. Kogan's evidence-based guide to the health benefits of cannabis and CBD, published in 2021, as well as the chief editor of the first definitive textbook of the field entitled Integrative Geriatric Medicine, published by Oxford University Press as part of Andrew Weil's Integrative Medicine Library series. Dr. Kogan is dedicated to helping patients with Alzheimer's disease identify and correct underlying metabolic drivers work, which is primarily based on Dr. Dale Bredeson's, am I saying that correctly?
Bredesen, it's okay.
Bredeson's research and newly creative Red Code Protocol. Sorry if I mispronounced that.
All
You
good.
can read more about Dr. Kogan's impressive background and efforts at gwcim.com and Dr. Kogan.com. It's DRMISHAKOGAN.com. And we'll put those sites in the chat for people as well. So welcome, Dr. Kogan. Thank you for joining us. And I'm going to go ahead and
Thank you.
turn it
Thank you,
over to
sure.
you.
Thank you, Danielle. Thank you, Kendra, for you guys, particularly Danielle, for carrying the torch for so long and making this group vibrant. Looks like we were just figuring out last time I was talking to you guys was in 2019. So it's good to be back. I have two parts to this talk. I want to repeat very little from the last talk, and I'm going to spend probably most of the talk talking about the cannabis just because I think it's completely changed my EDS practice. And we now have over 100 patients with EDS in our practice. And we actually hired two other providers who essentially seeing a lot of EDS patients. And my interest in EDS have arrived from just the fact that, I had a lot of patients coming to me. So, all right, let me just get going, skip some of this earlier slides. So as I was saying, the reason I got involved into this is I think kind of over time, just a lot of patients came to me for the fact that obviously if they're over 65 and I take Medicare, then I have a very large percent of patients over 65, and my understanding there are very few providers in the area who accept any insurance for EDS period. So in private practice, we don't take any insurances, so of course that creates significant issue for access. But if you somehow gotten into my university practice, that at least you can see me there with Medicare. And so I gradually learned the tools for EDS. Personally, I never actually formally got trained in it, but over the years, as we were seeing more and more patients, especially as my cannabis practice grew to way over 4,000 patients, I think I've learned to really quite effectively manage all kinds of EDS-related symptoms with cannabis. So that's why the difference is so big from 2019 talk, where I only talked about cannabis for a few minutes. Here it's the reverse. So today I'm going to start with cannabis. I'm going to spend probably close to 45, 50 minutes talking about it. And only then we'll switch and we'll cover some other topics, and then we'll do kind of an ongoing Q&A. So we're going to review some basics. I'm sure that a lot of you already on some form of cannabinoids, whether it's CBD, THC, or others. And, so some of this may be repetition, bear with me. I think the fact it's quite important to have a very good sense of basics and also to review some current evidence, but more importantly, really to understand why particular specifics of cannabis playing such a critical role in EDS. Okay. All right, I'm going to skip this. So, it's a very old treatment. Of course, we all know that. And by the way, it's kind of funny that I'm giving talk today, right? One day after 420, which is a national cannabis day. And even Biden and our vice president tweeted yesterday that they're in support of general legalization of medical cannabis. So in 1850 here, the cannabis was used widely in the US. Actually, it was a standard care across the large spectrum of diseases, as you can see. Interestingly, things in red over here on the slide are the things that currently reasonably evidenced, actually. And some of it actually FDA approved. So Epidiolex, which is a pure CBD, has been approved for certain types of seizures by FDA. So it's completely back on the map of standard of care. Okay. So some recent news, very interesting news. So a couple of months ago, actually it's more than now, a couple of months ago, this officially came out, I think in January, but the document was drafted almost a year ago. But in January of, this is incorrect, this is 2024 actually. There was a big statement that FDA is basically petitioning DEA to move cannabis away from Schedule 1 and citing there's a massive amount of evidence and and significant amount of safety. So basically what this means is that now even if DEA petitions the central agency that's controlling the cannabis to say, look, we have to change entire regulation. By the way, if indeed this ends up being in Congress and President signs this as an act, what we will see is basically cannabis will become available in every state and every pharmacy by law. And it was supposed to, they even would have to figure out how to get it covered by insurance. How this will happen, how quickly, of course, who knows, but it's an interesting way that this is happening as we speak. Of course, cannabis is one of the fastest growing parts of medical system. This is just in older adults, which is my main expertise, you can see pretty dramatic improvements. So just in a couple of years, increase was from 0.4 to 2.9. And then you look at the newer data. So this is just few years later, and now it's from 3% to 12%. So we're seeing this rapid geometrical uptick in an intake of cannabis for older adults. And, it's very consistent with evidence, and that's what I'm going to show you. And then we're going to talk about clinical aspects. So why endocannabinoid system 101? Well, it's not just because I want you to sort of know about THC and CBD. That's actually secondary. I think most of you have heard about this at least. But I want you to understand a little bit of what's going on endogenously, because we all make cannabis, and you will see that there's in a couple of slides, we have this whole idea of endocannabinoid deficiency. And there has been some work done on EDS and endocannabinoid deficiency, and I know the several very advanced researchers looking into this, and I have no doubt in my mind that EDS will become one of those conditions where it's a universal dysregulation of endocannabinoid system. Why? Hopefully in next 10, 15 slides, I'll be able to convince you why I think so. So, but what's happening normally? Well, normally, cannabis controls all these five points, and they're basically entirely under control of endocannabinoid system. If you have errors in how it operates, none of this will be possible. So you will not be able to relax, you won't be able to eat, you won't be able to sleep, you will not be able to protect yourself emotionally, and you will not be able to forget. So those are the 5 critical aspects. Now, of course, these things are all controlled by other mechanisms, but EDS, which is, I will use the words EDS, it's just easier, and the cannabinoid system for short, is the critical first step. So it's the regulatory step. And then all the neurotransmitters that happen after, they're all secondary. Nothing's going to happen on the neurotransmitter presynaptic, postsynaptic level if you don't have this first CB1 and CB2 receptors, depending on where you are. We'll talk about that in a second. So this is the most important part to understand. And look at this and think about yourself for a second. I bet that if you think about your own life, well, maybe with the exception of forgetting, but all this 1, 2, 3, 4 are probably in some way are affected. I mean, most of the patients with EDS that I've seen have anxiety, some kind of nausea, or some kind of eating issues, definitely sleep disorders, and then definitely sort of kind of PTSD-like states where your response to even minor neurologic stimuli goes haywire. So that's why I have no, and this is, by the way, why I'm spending so much time today on this whole topic, because I think this is the primary. I actually think that half of entire EDS pathology is depending on redisruption of ECS, and that's why I think, how do you work it in terms of modulating that? How is the exogenous cannabinoids fit? But more importantly, forget the exogenous cannabinoids, because you can actually modulate the system through literally probably dozens of different mechanisms. Many of them, acupuncture can very effectively modulate ECS. Certain vitamins can modulate ECS. Reverse is true. So you can work with on neurotransmitter level backwards and also have a benefiting the whole system in a way. So you have multiple different exercise. We used to always think that runner's high, or what we call an exercise euphoria, was related to the opioid system. That's completely debunked. It's completely wrong. It's 100% endorphin. It's 100% non-endorphin mechanism. It's 100% ECS system. It's been proven, and I'll actually show you how that happens. So CB1 receptor, the way to think about the whole ECS is in 3 parts. So you have CB1 receptor, you have a ligand. So the ligand is the molecule that binds to the receptor. In case of ECS, we're particularly thinking of 2 large and 2 endocannabinoid systems that you need to be aware of. So first is what's called anandamide, second is 2-AG. Now, there are probably at least 100 others. We don't know how important they are. Frankly, we know a lot less about them. We also know that they tend to be pretty complex. And frankly, it's probably not worth, definitely today, it's not worth discussing now. This is too complicated. The third part, so you have a receptor to which ligand binds. Ligand is just actual active molecule, or endocannabinoid, we call it. Then when the action, and then some kind of action is generated. So let's say in this case, what I'm showing you, you can take a look at something, let's say, maybe pain, right? So in spinal cord, CB1 receptors modulate pain responses, or pain sensation, or pain experience. So then let's say you've controlled that, so you've gotten under control, and you no longer need it. So then there's a third part, which is the enzyme that breaks the actual ligand. And then the cycle begins. So in essence, we're constantly generating and breaking down and the cannabinoid while the receptors are always there. And, it's continuous on and off, kind of like that. Interestingly, the peak development of ECS occurs way earlier than the rest of the body. So somewhere by the age of 12 or 13, ECS is mostly formed. The thinking is the brain, though, effects on the brain of ECS are, it continues to evolve until probably age of 25. So you may hear some of the most advanced cannabis experts discuss the fact that maybe we should regulate recreational cannabis after 25. I think it's a highly debatable topic. I don't think it matters for today's presentation. But generally, the peak of ECS occurs somewhere between age of 12 and 14. And then by about age of 50, about half of the peak is gone. So you're kind of down halfway. And that's where we start seeing that past 50, adding some exogenous cannabinoids in a very kind of continuous low microdosing level for most adults becomes actually a very important part, just like you would supplement with some vitamins. There is now a thinking that even evolutionary speaking, we were consuming hemp evolved products probably for thousands and thousands of years. In fact, I don't have those slides in this talk, but if you look at Chinese medicine, it was one of the most commonly used herb, and they didn't just use it for one indication. They used it. It was the only herb in Chinese materia medica that could be used for tonifying both yin and yang conditions. So it was a pretty unique scenario where it was very broadly used. But for us, really, the way to think about this, you really want to remember regulation of stress, trauma, and chronic pain. So those are the three big things. And the probably most important aspect of this is we always assume that cannabis works inside the brain. Of course, that's true, but it actually has a much more important peripheral effect. When we get stressed out, when we have pain receptors stimulated, when we're, let's say, in some kind of a, somebody yells at you or you're in a car accident or something, you first have this stress response that gets sent down, and you're supposed to normally have a feedback inhibition. So once the stress came through, the whole body gets activated through the amygdala, right? So the central nervous system. And then you're supposed to start inhibiting it backwards. So there's a constant back and sort of the balance in check. This is where often in this spinal pain pathways, this is where often disruption occurs in humans. And this is why by the way, we have a completely in total lack of effective chronic pain regulation, because we have no medications that are working here. None, they don't exist. Opioids don't work. NSAIDs have a little bit of activity. Some other medications, for example, like gabapentinoids, which we'll talk about this, that's for neuropathic pain, supposed to work partially here, but they actually don't. They mostly modulate that effect centrally. That's why we have a complete lack of any effective tools and, this whole push for non-pharmacological treatments. But guess what? That gets regulated by our own endogenous cannabinoids, but not by anandamide. This is critical. The break on this whole pathway here occurs through this molecule called 2-AG. And I'm not going to bother with you what that means, but in essence, it's a much less common anandamide, much less common than anandamide, but it still works like a lock and key. So it's still very similar to THC in a way. So you can totally indeed take some THC, particularly if you figure out how to take slow releasing THC and actually deliver it to the area where that is stimulated. Let's say you have a chronic, this is very EDS relevant. So let's say you have some constant peripheral micro trauma, just because your joints are more flexible, your connective tissues is not as they're easier to pull out of the alignment, they're easier to overstretch, they're easier to injure. The 2-AG becomes the most important molecule, and you will never have enough of it, because if you constantly overstimulate it, the system will struggle, and it struggle very quickly. Particularly, it will increase struggling with time. Remember what I said, the peak isn't like 12 to 14, and after that, you begin to drop it. And so that's why I think, my personal belief, why we're seeing in 30s and 40s that those patients with EDS who were not well managed in 20s, they get to really disastrous situations. That's because their ECS system is progressively weakening, and nobody pays attention to that, right? So you've never probably heard anything what I'm saying, because that is not a common information. I don't have a chapter of this in my book. I decided not to write this, mostly because I felt like that was just too complicated. And most of the patients who are reading my book are probably not EDS patients. Interestingly, I got scolded by a whole trauma community for not putting a whole chapter of cannabis for trauma. That should have probably been done, but we had to sort of decide what the readers would be most interested in. But the trauma and EDS to me are kind of a two flip of the same coin, right? So if you have EDS, you're definitely much more prone to any trauma, whether it's physical, of course, but also psychological, right? Your central nervous responses are always on hyper alert. They're always a little bit easier to tweak from one end to another, and then the recovery is slower too. So you're kind of a never winning situation. So could the ECS be a solution here? We'll talk about that more. I'm going to skip this. I don't think it's really essential. Okay, so those of you who kind of stickler to the evidence, I think I do want to talk a little bit about this particular series of slides on National Academies of Sciences report. Now, this is quite old now by the standards of cannabis 2017, that's 7 years ago, is really ancient. I mean, when you're talking about cannabis, things are moving really, really fast. But it's still probably the best summary of clinical evidence. And what's really funny is if you look at what's actually conclusive, look, for chronic pain, for nausea and vomiting, and for spasticity, right? So like basically all the things that patients with EDS commonly have. And then, there was a whole discussion, moderate evidence for sleep. Now, 7 years later, there was no discussion about, sleep and cannabis. It's now the discussion is what's the best way of delivering cannabis for chronic insomnia to get off of medications. There's a major national database showing that states that have approved cannabis seeing 50-70% decline in prescription medications for sleep. So, we're seeing a massive shift. And by the way, with opioids, we're seeing the same thing. That I'll show you in a couple of slides. But interestingly, that when you look at some other conditions, right here, for example, for certain types of other symptoms, they were saying for anxiety, it doesn't work. And it doesn't matter. In reality, this is summary of evidence for 2017. We moved quite a bit since then. And so this is a little bit more up to date. So this is 21. This is European consensus. In Europe, cannabis is used for chronic neuropathic pain as a first line now for probably 2 years or 3 years, somewhere since 2022. It took a little while for this paper to get, shift their practice. And the reason is quite obvious if you look at this. What you're looking here is blue benefit, yellow, it's a safety. So the standard currently in US is this medication called gabapentinoids. It's a collective term. Neurontin or gabapentin, you're probably most familiar, but there are other medications that are similar to this one. And look at the safety, it's 35 and benefits 25. So if you look at 1-to-1, THC to CBD, it's 15 points safer and 4 points more efficient. So based on that, Europe is no longer even recommending this medications because why? This shouldn't be the first line. So this is now the first line. Interestingly, CBD is a lot safer, but not even close as effective. We're talking about almost threefold difference in effectiveness. But THC doesn't give you a whole lot added benefit, pure THC, but it's a lot less safe. So you're looking at the big difference from 50 to 41, but only 2 points difference. Just if you're wondering about what about opioids, there's no evidence that they're effective at all. So, their benefit for morphine is almost nothing, right? So minimal benefit. So methadone is a little bit more effective. It's a type of opioid that's used when somebody is addicted to heroin, for example, or other opioids to substitute. It's a little bit safer, but it's obviously a bit more difficult to take. And also this duloxetine or Cymbalta is used quite commonly, but you're seeing again, it's not even close in the benefits and safety both. So, all right, I'm going to skip this. So remember I talked about endocannabinoid deficiency syndrome. So this is from a pretty old paper, but now we have a lot more current data. The person who leads this whole discussion is Ethan Russo, who's probably #1 current researcher and educator on cannabis. And he's a big proponent of this idea of this ECD, or endogenous endocannabinoid deficiency syndrome. And, he claims that this would be an etiology for anybody with this complete conditions: migraine, fibromyalgia, irritable bowel syndrome, psychological and other conditions. And, I talked to him some years ago about EDS, and he was basically saying, yeah, if you think about this, EDS must have component of ECS deficiency. What specifically, I don't think we know. I mean, it hasn't been studied. My guess is that we're looking at overutilization syndrome. So some conditions of ECS deficiency present as genetic from the beginning. So people with chronic lifelong irritable bowel syndrome from childhood are probably born with some deficiency component. But probably people with EDS, similar to fibromyalgia, it's an overuse syndrome. If you constantly have some chronic states like chronic insomnia, chronic pain, you're going to overstimulate your ECS nonstop. And eventually it'll start failing because you don't have enough capacity to create enough ligands. And that's been actually shown. So we do have data to show that if you take a mice and you knock out capacity to generate an anandamide or 2-AG, that these conditions appear immediately, like within just very short period of time when they're born and they have that. Similarly, you can constantly induce the pain and then measure the levels, and that's been done. So they're seeing a massive spike in anandamide, but then after weeks in animal models, they start gradually declining. So you no longer can make that. And nobody actually knows how to fix this. So we don't know what should you do to stimulate this. For example, if you're worried about serotonin drop in someone, you can arguably say, well, let's give that person a lot of tryptophan or a lot of 5-HTP with some precursors, and maybe they can make enough. With anandamide, we don't know. I mean, we don't know how to make more of it, right? We don't even know exactly how the body makes this, and we don't exactly know what the cofactors are. So but we have easy substitution with exogenous, which seems to be all in all rather safe and rather efficient if you're applying it with some basic principles, which we'll talk about this when we'll get to the clinical part of this talk. So, all right, so here's some data on combining with opioids, very safe. Every state that have looked at combining opioids and cannabis have seen dramatic decrease in opioid prescription. Now, this is just looking, I'm not looking at illegal pathways. I'm not looking at like heroin use or illegal fentanyl. I'm just looking about actual medications. This is my expertise. And to me, it doesn't really matter. Opioids are opioids. They kind of all roughly the same. They all work about the same. So if this happens in the population on who get prescribed medications, we're actually seeing exactly the same if you look at if you look at, so for example, this is mortality, all opioid related mortality over the years of implementation. This is a much older paper. If you go back here, this is 2018 and this is 2014. So there's a big difference. And you can see there's a dramatic immediate drop. So 20% in the year 1, by the year 5 or 6, you're seeing 35% drop in mortality related to the opioids. And by the way, I find it kind of criminal that this has never been discussed in any political circles as a way of getting out of the current crisis. I mean, we're still in the depth of opioid epidemic. I just came back from the conference in Cleveland 2 weeks ago, and we've seen some data. It's horrendous. Some states are actually the problem getting worse, not any better, except that now instead of sort of, oxycodone, now it's fentanyl. And it's a lot deadlier actually than an oxy. And so we're not out. And more importantly, there's a push to deprescribe, but there's no tools given. So patients are not given any real tools to say, okay, you have chronic pain, take this instead of opioids. And this data, look, this is 2014. We're talking 10 years ago, and yet nobody wants to deal with this. DA is still, by the way, have not given an answer to FDA about rescheduling. So, well, you should ask the question then, well, why cannabis does exist as pharmaceutical. This is a funny picture this is Lilly, which is Eli Lilly now. I don't know what, this is compounding, but back in the day, this is 200 years ago, right? Maybe, no, it's less than 200, like 150. So this is late 1800s, maybe early 1900s. And, point being is it was prescribed as a pharmaceutical back then. So why wouldn't you prescribe now? Well, the problem is we have no natural forms of THC. We have a synthetic THC on the market, which called Marinol, which only available as a capsules, and you can't even break them. They're this kind of a gel caps, and if you try to slice them, they're this viscous material inside. You can't dose divide. So the smallest dose, 2.5 milligrams. I'll show you that's an appropriate dosing to start with when we talk about actual clinical use for chronic pain. And then, we also have CBD now, Epidiolex, but that's only used for seizures. And if you want to try to use it, that's in liquid form. So that you can divide and take in any doses. It's very conveniently dosed. And I try to actually prescribe it off label And sometimes I get lucky if you have Medicare, Medicaid, both. I've had some successes with off-label use, and I often try to help my patients, and then it's completely covered with no copays. And actually can be very effective for certain situations, particularly for sleep. The problem is usually if it's not covered, which is 90% of the time, then you're looking at $30,000 cost versus if you buy CBD currently on the market, you probably will be spending 10% of that or even less per year. So it's a lot less expensive that way. But again, the pharmaceuticals are overpriced. Marinol cost to society is $12,000 a year too. So it's all the pharmaceutical cannabinoids are very expensive. Even generic. There's still generic Marinol, like it's still very expensive. Why? I mean, it's just the final. Okay, so let's shift to clinical. Actually, let me pause here and ask, because I realized that we didn't talk about THC, CBD, and all those things. We're talking about this in the clinical, but I didn't particularly discuss details of it. I felt like most people know what those are. So, and I'm sorry about the dogs. Sometimes they do get a little loud, but hopefully not for long. So if you have actually questions about THC and CBD, just drop them in the box. That may just be easier. Otherwise, I'll just keep moving to this part, to pain, nausea, and insomnia, because those are the three big things that are occurring, of course, with a lot of patients with EDS. Okay, well, I don't see questions, so I'm going to keep going then. Okay, so chronic pain. Well, chronic pain, very, very simple mantra. It applies to everybody. It applies to patients with EDS. It applies to older adults. It applies to anybody. Start low, go slow, and deliver where it needs to go. The whole body will use cannabinoids. If you take them orally, and let's say you need them for your knee pain, the percent of what will end up in the knee will be less than 1%. Why? Because the rest of the body will use it before it gets there. So if you have a knee pain and it's relatively superficial, guess what? Get a topical, put it right over the knee. And it actually, in most cases, work a lot better than oral because deliver where it needs to go. Back pain, guess what? Rectal suppositories, by far the best delivery mechanism. Neck pain, topical. Right? Now, if you have something central nervous system, so let's say you have seizures, okay, you have to figure out how to get it to the brain. So then you would use inhaled sublingual. Those would be the best. Or you will take so much orally that over time you will build up the therapeutic level in the blood. That will, of course, increase risk of side effects, right? So anytime you're increasing the serum level of any substance, it doesn't matter what the therapeutic long-term effect is, you're risking side effects. And as we know, of course, nothing is completely side effect free. Okay, so this is how I usually do it. I start with 1 to 3 milligrams. Usually I like to get complex ratios of things. If somebody has neuropathic pain, we use CBG with THC. If somebody has arthritic pain, so you have a chronic arthritis, then it's a CBDA with CBD with THC. If you have a pain that's more results of some kind of long-term post-trauma, so the tissue never healed, it has to ideally have THC, THCA, CBD, and CBDA. If you're applying this as topically, we call it quadruple topical or triple topical. If you can't get THCA, that's very hard to find. THCA can only be obtained from dispensaries nowadays. It used to be you were able to buy THCA without dispensaries. Now you have to use dispensaries. And of course, THC, you have to have dispensary. CBG is probably one of the most important newest cannabinoids, and I'll talk more about that in a little bit. It's particularly effective for anxiety and for chronic stress and for chronic trauma-like problems. So anybody with chronic neuropathic pain, with anxiety, with insomnia, and with PTSD-like symptoms, CBG is a number one molecule. Not CBD, not THC, CBG. Usually we'll end up with something else mixed in there because CBG alone is probably not going to be enough. You will end up with some kind of combination. Again, remember example of knee pain. Well, let's say you have a neuropathic pain, which is kind of a burning and numbness in periphery. Then you would use directly where you're hurting. So let's say you have fingers and toes. Okay, we'll start with topically putting it right there. If you can get this, great. I have not yet seen topical CBG. I think it's coming. CBG is relatively new molecule. How do you assess THC? Okay, well, edibles are fine, but they're not right. So you're not using edibles to treat the pain very well, right? Because they don't work really fast. They stay in the system for too long. Very unpredictable biochemistry. So the edibles should only be used at night, and they should only be used for insomnia. Everything else should be sublingual, sometimes inhaled. Like if you have a severe chronic pain, most people who are using inhaled forms, they just know that it's more predictable. The edibles are kind of really the child of the recreational use. People get very dense high with edible and it lasts longer. So, but for medical use, edibles are a lousy choice. They should be a last choice and no discussion basically. Why? Well, because sublinguals are way better and way cheaper. The problem with edibles, they're also way more expensive. So if you can get a Rick Simpson oil with something like 1,500 milligrams easily, you can get for $80 in all local dispensaries. If you want to buy 1,500 milligrams of edibles, you'll probably spend $500. So why would you spend this much if you can do that? And then you can make your own edibles from that. Right. We'll talk about practicalities of flower versus oils. Flower, if you're growing your own products, how are you going to make, can you make RSO or Simpson oil? Would it make sense make RSO? Should you just, by the way, just make tea out of flower? So this way you get a lot of THCA and then some THC and never throw any parts of the plant. Whatever flower left from the tea, you can actually eat it at night. And that'll give you basically a full edible effect during the night, right? Instead of buying it. How do you assess THC and CBD combinations to combine? Well, that's usually how I do it. So I start with sort of balanced products. So something like 1-to-1 CBD to CBG for neuropathic pain would be first step. If patient after 2 weeks tells me, look, I'm not any better, then I start adding THC, but I will not stop the CBG to CBG. I would potentially simply add on a little bit of THC. And I will start with just 1 to 3 milligrams and I'll titrate up. If a DS patient comes and there's no neuropathic component, it's all, say, a typical chronic pain in different joints, chronic frequent microtrauma, very unpredictable patterns, they migrate also, or there's some predominant pattern, like let's say let's just say there's a chronic back pain or neck pain commonly, right? And headaches, so those are very typical, plus some other joints. Usually you'll have to start with THC, and usually I will then start with 1-to-1 THC to CBD, and I'm about to show you a very typical case story. Again, if the predominant problem is a back pain, it's not unusual for me to start with suppositories as a first choice. Suppository is not always easy sell for people, but interestingly, it's very effective. And what's even more interesting, you can take very high doses of THC, get them into the kind of lower part of the body, especially pelvic floor. If you have any pelvic floor problems, suppository is godsend. I have hundreds, if not thousands, of patients with chronic pelvic pain totally transform their care with suppositories. The only problem with suppositories, they're super expensive. If you buy them as is in dispensaries, you're looking at something like $30 for 5. It's crazy. But you can make them. And our coaches teach people how to make them. It's cooking. If you're into cooking, if you're okay, following recipes and having everything lined up in front of you, you can make a month's supply for $70, versus if you're buying that, do the math. If you're using 2 suppositories a day, $30 will last you for 2.5 days. So you will need to buy 20 times. And that's 70 times 20. Well, that's 50 days, but whatever. You see where I'm going with this. It's way, way more expensive. Okay, if you're gonna inhale, which is fine, I think problem with inhaled is self-explanatory. Even if you're using very fancy dry flower vapes, you're still gonna have some cough. You're still gonna, if you already have a bronchitis chronically or a COPD, or if you just don't like the smell of it, I mean, it's not ideal. Frankly, to be honest with you, all these routes of delivery can be effectively utilized. They all have issues. So you have to really sort of try them out and decide if certain things are just out. Like a lot of people just say, I'm not going to put anything, I'm not going to inhale anything. I don't really care, you know. And by the way, when I say inhale, I don't mean smoking. We almost never recommend smoking, not only because it's kind of, well, burning anything and then inhaling it is going to have side effects for sure and long-term damage to the lungs. The problem is it's also massive waste, right? So think of it this way: you absorb about 5 to 10% of the flour when you inhale. So if you're buying an ounce of flour and you're only getting 3 grams out of this, let's say, and you're spending $250 on this, I mean, you can buy sublingual and get 100% of that, because everything stays inside. You're not exhaling 90% out. Just, you know, think of it that way. But, you know, a lot of people, I respect that. A lot of people come to me and they already have history of inhaled rub. They like it. Then we'll just transition them from smoking it to the vaping. Vaping is a lot safer. I never recommend vaping cartridges. Definitely just don't even think about that. There are preservatives in there. They're highly concentrated. You're losing certain active molecules, some terpenes not getting extracted. It's not a, I would never recommend. And plus, there's obviously been this massive debacle with some kind of a off-label use preservative. We don't even know exactly. Some people think it's vitamin E acetate, and then there were thousands of deaths from those bootlegged black market cartridges. We don't see that in medical cartridges, but it doesn't matter. I mean, I would never put synthetic preservatives in my lungs. Why would you, if you can just actually get flour? More importantly, if the flour now can be basically free, right? So if you live in any state, you can grow. DC, Virginia, or Maryland, we all can grow in every three states. In Maryland, you don't even need prescription. You can just grow 4 plants recreational. So frankly, in all states, I think it's true now, you don't need any medical prescription for growth. There are some limits and sort of restrictions. People always say, whoa, but it's so difficult. No, I mean, there's a reason why we call cannabis weed, because it grows like one. There are some basics you have to learn. There are great books on the topic. You're going to spend a little bit of money on seeds. Maybe, you know, every year you'll spend $50 on seeds, but then you can potentially make a few $1,000s worth of product that will last you a whole winter. You basically harvest it in the fall and then you freeze it and you keep it in the freezer and you have product for the rest of the year. So if you smartly using it, you can even learn how to extract it. Now that, again, it can get completely off track here and get very complicated. I'm not saying that most people will end up doing this, but if you're like farming or if you like gardening, I don't see a reason why you wouldn't add this. Of course, there's some safety precautions. It's a highly valuable crop and people do steal it. So you would want to then make sure that you somehow grow it on your balcony or something. Okay, so let's move on. So here's a case, very typical story. I do get a lot of consults like this when patients are getting Medicare and they can come and see me. So she's on too long a list of medications, still working, severe pain. So, you know, so something like combination of acupuncture with the THC twice daily, on top of everything else she's already been doing. Compression stockings, keeping her blood pressure up and all those, taking a lot of salts in. So this is very typical endpoint regimen. So about 10 milligrams of THC twice daily plus 50 milligrams CBD, CBDA. There is no point doing CBG here because she has a kind of a typical arthritic component on top of her long-standing EDS pain. So now, so CBDA and CBG. So these are the 2 things that you may not have heard of. I decided to talk a little bit about them separately just because they may be new to you. So CBDA is the acidic form of CBD. It's literally cannabidiolic acid. The A is for acid. very potent anti-inflammatory. Actually, it's itself in isolation can be used instead of Motrin. It's about 10 times more potent than ibuprofen milligram per milligram with almost no side effects. Why? Well, it's a COX-2 selective inhibitor. The ibuprofen is non-selective inhibitor of COX-1 and COX-2. Because of that, we have a lot of side effects. And you're not going to be able to overdose it. That's not a big point. If you take way too much, you're just going to hurt your wallet, basically, and you're just not going to do that. There's other effects. We don't exactly know what they are. And the reason we don't see side effects and drug interactions, there's no there's no liver interactions. So most of the cannabinoids, THC and CBD both included, they're pretty significant liver interactions. This is what's called cytochrome P450 system, CYT-P450. I'm not going into details of that. I don't feel it's needed for this talk, but if anybody's interested, just ask. But bottom line, each cannabinoid, except for acidic forms, except for CBDA, THC, and CBGA, they have pretty significant interactions. Most of them are probably only theoretical because we're not seeing problems in clinical realm. Okay. CBG is the most recent one, and there's also CBGA now, cannabigerolic. This is cannabigerol. Cannabigerolic acid, fascinating molecule, very different from CBD and THC. It's a pretty potent appetite stimulant, has a shockingly both antidepressant and anti-anxiety effects. So we do know that it works on serotonergic pathways. We do know that it's pretty potent antidepressant and mild anti-anxiety effect, but pretty potent neuropathic agent. It actually can cause very serious side effects. We have seen people not just with nausea, but with kind of disorientation at the high doses, similar to THC. It's not high, but it's kind of state of detachment. You feel like you're not just dizzy or lightheaded, but you feel kind of dissociated, and it's not a very pleasant state. Dizziness also very common. Happens with very high doses, something like 50 milligrams. Most people will start with 5 to 10 milligrams twice a day. So it's kind of not easy to get to that high dose. But we have seen this when people just didn't realize that this was CBG. They thought it was CBD, and then they took like 100 milligrams right away, and then they were in trouble. So, obviously you need to read labels, but okay. Nausea, definitely excellent tool to use. I have no doubt that some of you using it for this particular indication. Sublingual and inhaled, really where you want to go. You probably don't want to swallow any THC. Most effective anti-nausea is actually THC. However, both CBDA and CBG has some anti-nausea properties, much less. Definitely, if you're nauseated, and especially if the nausea is interfering with your eating patterns, THC is your friend. Usually, I tell people take sublingual, take low doses, take regularly before meals. So that's usually the pattern. So something like 3 to 5 milligrams, even less. You can start with 1 and then just keep taking it before each meal. One important point, it's okay to underdose and really just get to the right dose. There's this idea of a J curve. So imagine this kind of when you start the treatment at the dose, you're not going to have a benefit yet, but it'll start training your receptors to see the dose. As you gradually go up, eventually get to the bottom of that J curve, that sweet spot. At that sweet spot is where you're going to have control of symptoms, let's say nausea in this case. But if you keep taking more, guess what? Not only are you going to miss that set point, so you're actually going to return your symptoms, you can exacerbate them. So overdose of THC causes this very well-known condition, chronic hyperemesis syndrome, very difficult to treat. We don't see this in medical practice. This is recreational problem. So when people take 50, 100 milligrams, mostly smoking. So you end up inhaling such an excess of THC that the thinking is this somehow messes up with the nausea center in the brain. And you have this completely dysregulated situation where you actually vomiting when you're not using THC. So people think like, oh, I need to use some, and then vomiting stops, but it actually just restarts the cycle again. And so it's a very difficult condition to diagnose and treat. It's both overdiagnosed and underdiagnosed. And I've had referrals from for this condition is completely wrong many, many times. And yet I've also seen patients who were missed by the ER. But generally, ER is dealing with this ever increasingly, especially now since the recreational market is booming. And, particularly we're looking at like young adults who are taking a crazy amount over time. One of the problems, if you're not careful, if you're not taking breaks, if you're continuously going after high, the dose will keep going up. The tolerance is a real deal. People get tolerant all the time. In clinical settings, we know what to do about it. We generally will have people do a 1 day with a drop in a dose or completely free, what's called a washout day. Sometimes we don't need to do that. Sometimes we simply can keep adding slightly amount of THC, but then we'll balance it with CBD or CBDA, and then we would not ever get to any real long-term side effects, but it's a situation, it's a condition that everybody should be aware of. So, okay, insomnia, probably the number one. Often I discuss insomnia first. I decided to put this here as a last, mostly because I felt like it's actually the most effective method of cannabis, so I saved it for last. In my experience, you have about 80 to 90% response rate immediately. We're talking about within less than a week. And the idea is quite simple. We all know that melatonergic pathway is the sort of triggering the sleep. And that may be true, but how all this happens and how do you make melatonin? Well, it turns out it's completely 100% under endocannabinoid regulation. So you actually have to have an anandamide spike somewhere in the evening to start producing melatonin. You're not going to make it if it's not there. So thinking goes like this. And those of you who have tried melatonin and have seen absolutely no effect, it's very consistent with this logic. We don't have a proof of it, but it's consistent with this logic. It doesn't matter how much melatonin is in the system. You can swallow a ton of it, but it needs to get to the corrected places and it needs to trigger correct signaling. That is under the ECS. You have to have a CB1 receptors triggered. And if you already have an endocannabinoid deficiency or for whatever reason, you're not going to have that impact. And the sleep seems to be the most sensitive area. So that's usually where we start. So if I would have a patient with EDS, I will always start with sleep. And why? Well, because the dosing of cannabis will be the lowest. I often can get away with 5 milligrams at bedtime, which will cost $30 a month in that range. We always start with some balanced products. We always titrate it starting from 1 to 3 milligrams. Takes about a week to get there. Once you know your dose, you can try edibles. Why edibles? Well, edibles are actually often preferred for the night because they're going to last a lot longer. They kick in within about an hour and then they can stay and continuously work for about 8 hours. In contrast, if you do inhaled, it'll be a great way to fall asleep, but the effect will wear out in an hour or two. And then if you wake up, then you have to smoke again, and it may not work second time. So, the same with sublingual. Sublingual will take about maybe 40 minutes to kick in, and then you have about 2 to 3 hours. So it's much shorter acting than edible. Which form of edible, whether you're making your own cookies or you're buying, probably here I would buy an oil and I would mix it into something where you can control the dose. The problem when you're baking, let's say, flour into a cookie, you will not know the dosing. So each batch will be a little different. It will be a little hard to know exactly how much to take. But nonetheless, I have a lot of patients who actually prefer that anyway. They just prefer to take an edible at the dinner. They know it'll kick in about an hour. They know that they'll get kind of really sleepy later, and then it'll work. Now, a couple of words on here. We didn't talk about this smell molecules, the terpenes, right? But the terpenes are critically important. Let's say you're going and you're going to buy a flower that you're going to smoke or drink as a tea or cook with. And let's say you bought by mistake, let's say you're trying to do this for insomnia, but let's say you actually bought a stimulating variant. you bought something that has limonene or pinene or one of those uplifting and stimulating terpenes, well, you actually could disrupt the sleep even more, because THC will be acting on your system, on central nervous system, based on the terpene content, not just on its own. And so this whole idea of indica versus sativa, we try to get rid of this wording because it's very confusing, and most of the variants don't have anything to do with the actual indica sativa. Everything hybrids now anyway. But the old idea of indica was that sort of it's a mellowing strain, right, or a mellowing variant. So you will take it and you'll kind of feel relaxed, less anxious, sleepy, versus sativa will kind of be stimulating. That's based on the terpene content. There's a wonderful resource, and I'm going to show you. Just stop sharing just for a second. The resources I decided not to include. Oh, why is this happening? The resources I decided not to include on the slides just because I felt it would be too much. But, so the terpenes would look, so this is Trichome Institute. I love this diagram. So you would have kind of this map, and this is just a couple of dollars, called the weed wheel. So you would say the lemon, sage, roses, and pine. So this would be like uplifting. It will be very stimulating for the brain, and then on the other hand, something like, let's say, lavender, thyme. So this would be like down effect. You will be more sleepy, etc. There's also this wonderful book. It's a little bit pricey. I think it's like $50, but if it's called terpening. It's very, very practical, and it's got you got the same cycle, but this also shows you how you can it walks through the history here, but then it actually shows you some critical strains and describes how some of this happens here. And this is very, very practical after about half of it. It actually begins with like, what would you take somewhere around here? So starting around here. So perception of aroma and how it impacts us, etc. So this is pretty important. Why? You want to learn how each particular terpene affects your system. Some of those things, resources, usually where you find them. So the Trichome Institute, I'm going to write, you just buy the wheel directly from their website. I think it's like $10. Trichome Institute. And also the book is there too. Trichome Institute. I put that in. I think it's just Trichome Institute, or just Google that. It has to, I think it's just trichomeinstitute.org or .com. They're an educational company. I think they're actually selling terpenes. You can buy terpenes now in the little cotton swabs or as an oil, like a little bottle. And then you can literally buy your own THC CBD, and then you can add a couple of drops. I have patients do this all the time. There are also several companies now that would let you customize the blend. And I'll show you that in a minute. So let me go back to the slides. Okay, I think it's this one. Right, and then I see that there's a question. Let me go back to the chat. Okay, do you have any suggestions for strand and THC? You mean strain? Is that what you're saying? Okay, so increased heart rate, that's a great question. So increased heart rate occurs with THC. So if you take enough CBD, it'll suppress that. In fact, I have experimented with a lot of people to take a high doses of CBD for tachycardia, and sometimes it works. So sometimes high dose of CBD will suppress the heart rate. That would probably be not the way I would use it, right? Because there's so many other things we like to use for dysautonomia. So I wouldn't use, just because the price. I mean, yes, you can use it, but CBD, you're going to have to use hundreds of milligrams per day. It's just going to be pricey. So it would be not the thing. But that's also the reason why, if you noticed, I've never mentioned any unopposed THC. I never allow any of my EDS patients to take pure THC, because it actually can dysregulate. It can worsen dysautonomia. There's a good data on that. It's a kind of the same situation with ketamine. there's some people who are going to be very sensitive to ketamine, and they actually it will cause tachycardia periodically. But for some people, sometimes ketamine, even at low doses, becomes regulating. So, MCAS kind of doesn't really people. So this is a different situation, right? So the MCAS, which is the histamine overproduction, that's a little different. I don't think of that being related to this at all, except for one thing. If over time you effectively balance the central nervous system, we do know that MCAS usually gets slowly better, but it's a secondary effect. As you improve central nervous system general response, the hypersensitivity to any stimuli begins to drop over time. It's a really good question. Yeah, so tachycardia, fast heart rate, is one of the most common side effects, mostly in recreational use. You'll have to take a lot of THC for this to happen. When you're talking about 10, 15 milligrams, probably not. So this is the pretty dramatic case. So this was a 41-year-old woman who came to me with really severe insomnia and very poorly managed EDS. I'm not going to bore you with the, I mean, she was on oxy, but look at all this medication. She also had history of seizure disorder, pretty dramatic. So we basically, and she was referred for sleep because she heard of me giving a talk on sleep and cannabis, and that's what she wanted it. So that's how she came to me. I think she came from Pachinki, I want to say. He didn't send her, but I think this particular patient, why am I not switching? Okay. So 3 milligrams 1-to-1. So this is a very, very low dose. You can titrate it pretty quickly. So if this doesn't work, the next night you go up to 4 milligrams or even to 5, and then to 6. And then you keep going up every night until you get to a zone where it's working. So 3 months later, off of all medications. Let me go back here. She even decided to get off of Keppra. She simply took a lot of CBD and she still has not had any seizure. So this is a case where one product basically got rid of management, basically improved management of those 3 major problems: the pain, the sleep, and the seizures. Now that's a little gutsy to get off of seizure meds, but she actually has not had seizures on Keppra for years anyway. So I think her neurologist was comfortable trying this anyway. All right, so that's this part. So I'm gonna, by the way, the book is on wherever, Amazon. If you're gonna look for it, look for the updated version because it has new information of CBG and CBGA. It's a self-cover that came out last year, exactly a year ago, March 23. The original book was published in 21 by Random House. So, okay, I'm gonna pause here. I'm gonna stop sharing slides. We have about 20 minutes, right? So what I'm gonna do is I'm gonna see what questions we have. And I actually think that it's probably wiser if I simply open up and say, what questions do you have? And then if there are no questions, then I can show you some of the slides from the talk I did in 2019. There are still a lot of things that apply. I particularly want to talk about methylation and some of the changes in methylations and how it actually relates to dysautonomia and MCAS. I also can talk about ketamine because we've gained a lot of experience, especially now that we have so much long COVID patients and they all have POTS. And even now with the ketamine, we're seeing a pretty dramatic improvements in POTS pretty rapidly in the right settings. And the last thing we can also talk about methylene blue, which is the new big thing. So ECS and LDN, it's a great question. So remember, LDN is an opioid tuning. ECS is the primary key switch for the endorphins. So the way this works is the pain response of endorphins starts with ECS first. ECS sends signaling to the endorphin system, and then that pathway gets stimulated. So that's why everybody should be on LDN. If you have chronic pain, you have to be on LDN. That's the first thing. Why? Low cost, pretty much no side effects. Works at about 50-50, flippable point. But when it works with no side effects, and you can, by the way, it could be free, right? Because if every dollar counts, you can buy 50 milligram tablets, take a tablet, drop it, crash it between 2 spoons, put it in a sterile water, a 2-ounce bottle, or even a 1-ounce bottle, but 2-ounce probably easier. And then take a teaspoon at night. So that basically will cost you nothing because it's a 50 milligram as a prescription and will be covered by every insurance. Oh, sorry. The question was, how does the ECS interact with LDN? Oh, so nobody can see the questions, only I can. Okay, so now I'm gonna repeat, I'm gonna read each question. So before that, the question was, the one I answered before, do you have any suggestions with strains and THC CBD considerations for use for folks with MCS and POTS, particularly curious around increased heart rate? Does the same idea of starting low and increasing apply, right? So I answered that, and the answer is yes. Is there a genetic connection between Alzheimer's, EDS, POTS, MCAS? My grandfather, mother, and all developed Alzheimer's at 72 and lived for 8 years. My 19-year-old daughter has EDS. I have symptoms of it. I just learned 2 female cousins have EDS. Yes, the short answer is absolutely. Very high propensity of ApoE4 mutations in patients with EDS, about double from your typical ApoE4. And that's the feared Alzheimer's gene. The good news is that that's completely reversible now. So we have that Bredesen program we mentioned, reversal is about 74%. We're in the middle of kind of working all this for publication, but the effects are dramatic. We've had now some patients about 7 or 8 years, no Alzheimer's. They came in moderate Alzheimer's, they're completely normal, and they've already been normal for years with us. We're seeing it's the same principle. If you treat the driver of the condition, right? So instead of patching things up with beta blockers or compression stockings, if you're actually addressing the driver, so Alzheimer's have probably 30 drivers, EDS probably has at least 20 drivers. You have to address the drivers, right? So I've only covered in the cannabinoid system, which is a big driver. It's very actually interesting. So ECS is critically important in Alzheimer's disease, no questions about it. But the data is very hard to find because you're looking at a condition that evolves over many years, hasn't been studied very well. But all my patients with Alzheimer's on some kind of cannabinoid extracts, and usually not THC. THC becomes not as important. You can stimulate endocannabinoid receptors with your own endogenous molecules if you just continuously putting people on CBD, CBG, and some others. We didn't talk about CBDV, which is really an interesting new molecule for the brain health. It's kind of beyond today's talk because I don't use it for EDS at all. It's really more memory induction and particularly terpenes. So we actually use terpenes for everybody. You don't need to use any cannabinoids. You can just buy terpenes and use them. You can also go into a pine forest and breathe them in, and actually it works. And there's a quite clear correlation between inhaling terpenes in different ways with effects. That's actually why you would hear all the time experienced cannabis users would say, well, if I don't want to get kind of stupid on cannabis, I'd get a strain that has a lot of pinene in it, that smells strongly like pine, and I'm fine. I can smoke it and still do work and still cognitively perform, right? Well, that's how you offset it. The whole idea that cannabis can cause memory loss is just completely outdated. You can damage the brain in young developing brain by taking too much THC, but you're never going to damage the brain once you're past 30. You can cause some problems with it, definitely. You can cause some long-term side effects, but you're not going to worsen the memory. You're going to have a short-term impact if you're not paying any attention. So if you're using recreational strains, if you're not thinking about it, but if you're doing it appropriately, it's the reverse. You're actually going to support the brain.
I had something from someone. Your previous slide talked about the morning lethargy with edibles.
Right.
Do you have any suggestions on how to counter that if somebody has found a good dosage to help them sleep? Is it take it a lot sooner, or is there something else that can be done?
Yeah, so you can take it earlier, much earlier. So let's say you're eating dinner at 7, right? And you're going to bed at 10. let's say, right? And you found that you need to take edible at 9, well, you can take edible right after the dinner, right? And then it'll actually slow down kicking in. And it will still last for you for 8 hours. That's one way you can do it. You can also get up in the morning and actually take a CBD with a lot of pinene. Let me actually show you this real brief. This is just one company. I mean, I'm sure there are others. This is the one I use, and I can give you guys the discount code. Also, if you're on Medicaid, they have a compassion program, so that gives you 50% off. And you can tell them I send you. I'm not getting anything out of that, by the way. They're just going to give you discount faster if you use my name. All right, so that's if you're not on Medicaid, I'll put the code in a second. That's my code. So you can actually buy, let's say you're going to buy a morning, like just some pure CBD for the morning. When you're buying it, let's say you're going to get something like 3,000. So this would be a daily 100. So let's say you want to take 50, half a dropper. So this would last, one bottle would last you for 2 months. When you're buying it, that's 2 ounces. So that will last you for 4 months. You don't even need 2 ounces. Let's say you're going to do 1 ounce. So that's 2 months supply. And that's before the discount. So let's say you're going to do whatever. Then you can pick, let's say, pain relief, and it'll give you a mix, pre-mix already. Or you can go down and you can select like both pinenes, for example. And then if you know that limonene is very stimulating for you, you would also add that, right? So then they charge you like 25 cents for each here, right? So then you will put your code here. Now, if you have a compassion program, then you will just use that and it'll be 50% off. So it'll be 70, whatever. And this would be, so that's like $37 a month. So that's one way. You can also just get terpenes directly and try them. And you can put terpenes into anything. I wouldn't put them straight under the tongue. It's very, very strong. I would mix them with the food. I don't know, maybe like if you have a breakfast, let's say you have a yogurt, you can just put 1 or 2 drops. It's going to be pretty cool. Like you're going to have a yogurt smell like pine. There's nothing wrong with that. It's not going to change the taste. It's just going to smell strong.
I just have a quick question. It's easier for me to ask it. In reading all this and listening to all this, are there any studies or can you talk about it for use in teenagers with EDS?
Right.
Or
It's exactly the same.
Specifically, like
everything is the same. No difference. What you will not use unopposed THC at all. You will always mix it with CBD and others. I have a lot of teenagers in the practice. We use it, and we don't have a problem. You have to get over a stigma. You have to get over, oh my God, my teenager's going to. Remember, if you're doing this with a medical aspect, you're starting low. It's not going to be what kids are smoking in the school. You're going to be getting different products. They're going to be. Let's actually do this because I think it'll be practical. Okay, no, I'm not. So you guys, I'm gonna pick on myself. So I'll just give you. So I live in Tacoma Park. So I'll give you a Tacoma Wellness, which is just a couple of blocks from where I am. So and whether you're in Maryland or in DC, they're located in DC, but you can go there with Maryland license. And they have the reciprocity. So I just want to show you what's in there. Just going to show you the actual menu. This way it's so like there's some tax-free right now, I guess, because so you will click on categories, right? And then you will pick what you want. So let's say you want to get, somebody was asking about edibles for the night, right? So let's look at what they have. The edibles usually going to be some kind of lozenges or chocolates. Honestly, I think that capsules can be great. The capsules tend to be very pricey. And I'll show you what I usually do. I usually tell people to get, not atrocious, but to get gummies if they have them, or chocolates. And the advantage is the atrocious are hard. The chocolates, let's pick a chocolate. Let's pick, so this is probably, let's see, is this, okay, that's 5 milligrams. No, we don't want that. You want to pick always the highest potency because you're going to save money. So I think this is the one. This is 40 milligrams. So this is 400 milligrams for $60. Let's say you figured out that you need 5 milligrams, but they have 40 milligrams. So, that's going to be a little hard to break, right? Because you would need to chop them in 8 pieces, but you can. right? So these are the tablets, though. The tablets are going to be hard to break. You will need a pill cutter, and breaking them in 8 sections is going to be potentially hard. But you can break them in 4. So if you're using 10 milligrams, this would be perfect, because then you will have 4 tablets, 4 doses for 1 tablet, right? So then this is a 40-day supply for $60 for edible. That becomes, decently priced. That's how you need to think. Because if you're not going to think this way, and they're going to do what they're going to tell you, which is, oh, just buy, they're going to try to sell it. They're in the business of selling it. But you can do all of those things. So then also, of course, let me show. Remember, I was mentioning the Rick Simpson oil. Sorry, that's not the right. It's going to be under tinctures. So these are the typical tinctures. You would have to find where it's actually an alcohol. We don't recommend. You want to use something like an MCT oil. This is not a Rick Simpson oil, but look at some of this. So this is the high concentration. So this has 1,500 milligrams of THC and only 400 milligrams of CBD. So I would take this, which is 1 ounce, and I would then literally have people buy from Miriam hemp this 3,000, and I would have people take half of this, and then what happened? Oh, I switched the slides by mistake. 1 second. Okay, you still seeing my screen, my Miriam hemp? What are you guys seeing?
We're seeing the Miriam Health.
Okay, great. So I would take half of this bottle, and I will tell patients to mix with this, because this is 1 ounce. So you will need to buy a 2-ounce bottle on Amazon. It'll look like this. So 2-ounce empty bottle, because you want a dropper inside. So this would not work. You would need to have a 2 empty amber bottle with dropper. So you would need to buy something that looks like this. So this is 2 ounces. So you can get like I don't know, here's 4-pack. So this would be plenty, because you can then, so you would get this, and then you would mix half a jar of this with a full jar of that. So now this would be in combination will give you 1,500 milligrams of each. So if you're using 10 milligrams as a dropper at night, right, and you will mix it, then you will say there is now, instead of 1 ounce, 1.5 ounce. So you would need to calculate accordingly. So if you have 10 milligrams, there's 150 doses. See how cheap this gets? If you're only using 10 milligrams at night, and it's 150 doses, this is going to last for 5 months. So that's the good pricing. Rick Simpson oil will be about the same. So in essence, it then doesn't matter. You can use this one, or you can use ours. So, but this is how you think about cutting the cost, and this is how you think about getting it. Generally, the default for 2/3 of all the patients start with something like this. Now, of course, if you take a dropper of this, suddenly there will be so much, you will be way too high. So you have to be careful. You have to know the dose. You have to start low and titrate up. But you see now, this one is even cheaper. That's 1,000 for $40. That's how you think, but that's an alcohol. If you buy it in an alcohol, you cannot mix this with oil. That's why usually everybody just buys oil and then mix it with something else. And oil is also great to use in a topical. So you can take this and then mix it with like a shea butter or even a coconut oil. You can then, instead of buying a bottle of a dropper, you would buy 2-ounce jar for topical cream. So you would just buy something that looks like this. So this is 2 ounce. And then you would mix it. You would make a larger, potentially. You can make an 8 ounces and then make 2-ounce jars. So then, you can also buy topical. Let me show you. You can, from the same dispenser, but they charge a lot for topical. And that's just because it costs them extra money. Oils is the cheapest because it's a starting material. By the way, this is Rick Simpson oil. So this is not any cheaper. This is mostly CBD. That's very expensive. I don't know why. District Cannabis is a great strain, great brand, and they're usually very cheap. So I don't know why. You have to keep an eye on basically just what's in the moment specials. Often I tell people just go to specials and figure out what you're looking for. Okay, but let me show you topical, as I promised. So something like, okay, this is the one I often recommend. So this is the district canvas, is probably one of the better topicals. So this one, Fire and Ice. This is awesome for neuropathic pain. So this is 1-to-1 THC to CBD with cayenne. And cayenne is very good for it's actually used directly. The hot component is used quite often directly from your bed. But look at the price. It's $90 for 400. You can make your own. And literally, we have a protocol how for people to make it. You just need to, it's a little more complicated than just mixing it with shea butter or coconut oil. They use coconut oil here because you need to, see, they have a lot of molecules that make it dispersible. So they use this PPG 20. Often we just use lecithin. You don't have to have all this complexity. You don't need any of that. Just the lecithin will be enough to spread it out. I think for the, I don't know what's here for what they use for ice. Usually it's menthol, but I don't see menthol listed here, but okay. All right, let me stop sharing and go back to questions.
I had another totally off-topic question
Sure.
from what you were just talking about.
Uh-huh.
Security clearances in medical cannabis, is that still a no-no?
Still no. So if it's a federal, forget it. I have nothing to say, unfortunately. So what's changing is what I've heard. If your leadership is supportive, they will tell you that, look, we need to get we need to get your urine soon, and then you will have to stop. The problem is, though, if they need to have you write something legally, whether you use it or not, you will have to write it. If your job depends on this, then forget it, right? But if you have a very, very good leadership and they are going to be sort of potentially tolerant for medical use, and you have a recommendation, it may fly. I've had few patients who say, I don't really care. I'm going to keep using because it's the only thing that works for me. And I'm going to have me write them a letter. I don't recommend that because on a federal level, that letter is going to have absolutely no weight. It doesn't matter that it's legal in your state. You're on the federal regulation for security clearance. So I don't know what to say. There was a question about digestion. Yeah, so generally, if you have an IBS, you need to take it orally. And one of the best ways to take it is in capsules. And you can buy capsules, actually, they're there. You can buy 2.5 milligram capsules. You can also make your own. You just take the same oil, buy empty capsules, put 1 or 2 drops, depending on how much you're going to take. And that's a lot cheaper. In fact, remember, see how I go back to the same thing because of the cost. Capsules can be pricey if you buy them directly, already premium. But orally, capsules, low dose, you're not going to get high, no more than 2.5 milligrams. If you're super sensitive, you may need to start with 0.5 milligram. I'm not kidding, it's that low. But often that regulates the bowels quite a bit. Again, it's the same idea. IBS, actually, that's been studied. So in patients who have IBS, particularly with constipation, it's definitely an endocannabinoid deficiency on the level of smooth muscles of the gut. You don't have enough receptor activation. So motility depends on an andamide. Actually, it's 2-AG more than an andamide in gut. So you can replace it with THC. But you have to have it in the capsule because if you take it under the tongue, it's never going to get to the gut. And effect usually does not reach the colon. So for the colon, you would need to use suppositories. That I rarely do because that gets a bit too complicated. It's not about strains, it's about THC for digestive issues. So you would just get capsules. So let me show you. Go back to the menu here. So instead of topical, you would get to edibles. And remember, we skipped kind of this quickly, but here, see, these are too powerful. You would need to take 2.5 milligrams. Often they don't even have 2.5. And you don't want to do chocolates because they're going to absorb too high up. Capsules will not open up until they pass the stomach. That's why I see. And none of this is, there's not enough capsules. So what you would do is you would buy that oil I showed you. Then you would go on Amazon and you would buy like empty capsules, probably 0 empty capsules. Let's do size. Well, so they go the larger size, the smaller the capsule. So this would be the, very small capsules. But it doesn't matter if you're only using a couple of milligrams, that's the size you want. So here, I don't know. I mean, they cost very little. That's very expensive. I mean, you should buy 1,000 capsules for $10. Don't buy for easily find here. Here's 500 for $13. 5. And gelatin is fine. Now, if you're vegan, you'll have to find vegan. So here's some vegetarian cups. Gelatin is better. Actually, you need to look for, it should say enteric-coated. That means it will pass the stomach unbroken. Gelatin potentially will start opening up in the stomach. So you want to try to have it open past the stomach. So it should say somewhere here, you could just put empty capsules enteric-coated. So though this one should be enteric-coated, if hopefully. I don't see that, by the way. Let's pick on something and see what it says. You would need to read it here to see if indeed that's correct or not. I don't see it. Well, usually when they have this dark color like this, they're not going to open in the stomach. They're going to pass the stomach because that's the enteric-coated color. Typically, even though it's not described here. So, all right, let me go back to the chat. Right, so for the diarrhea, particularly for diarrhea, you would actually then make sure that there's very little THC and you will try CBD, same way. You will put it in the capsules. You cannot find CBD capsules in dispensaries, but there are places where you can buy CBD capsules. So this is another brand I like, and they have capsules. So you would come here and they have capsules. I mean, they're a little bit pricier. So here, 90 capsules for $80. So this would be a month's supply. You will take 1 capsule with each meal for the diarrhea and bloating. Now, of course, diarrhea and bloating may have nothing to do with the directly EDS, right? You may be having SIBO, and you would need a really functional medicine workup, which we sort of ran out of time, but I can only do so much. I decided to kind of spend most of the time on this because, again, it's dramatically changed how I practice. It's not changing my functional medicine practice. And, if I come back within the next 6 to 12 months and talk to you more, then we can do the other part. We can do the part that I cover all these other things. But, I always joke that no matter what your problem is, remember that we still have all the milieu of all other issues that can come up in our lives. So EDS has predisposition for certain things. And of course, those are the things we talked about, but we see a lot of SIBO, small intestinal bacterial overgrowth in EDS patients. Why that happens? I actually think there are 2 reasons. So one, when motility of gut changes, the normal flora alters over time because you need to slough off and have a normal bowel movements, a normal movement of all of the materials, both food and then the digested materials down so that bacteria is happy. Once it starts getting altered either way, over time you will start having microbiome shifts. And patients who have constipation usually end up with a SIBO. It may take some years, but it usually ends up being there. But that's easy to test. It's a breath test. It's relatively easy to treat either with antibiotics or with herbs plus the diet. So you just remove certain types of what we call low FODMAP foods getting introduced, and you kind of remove high FODMAP. So those are the fructooligosaccharides, which are the molecules that getting fermented by bacteria. That's what's causing the bloating and diarrhea often, or constipation, either one.
Well, we have gone past
Mhm.
8:30, and I think, we could keep you for another couple of hours, but we won't do that. So we will have to have you back in a bit to talk about the other sort of integrative approaches from sort of the lecture you did before, which was
Mhm.
fascinating, and I know helped a lot of people think about different things uh, to their treatment and what was going on, which other doctors had not mentioned, since you look at the whole body. So anyway, we will have to have you back, and we will let you go watch the chess game. And
All right.
thank you
Thank you,
very
Dr.
much
Kogan.
for this evening, and I will edit
Let
out
me
the
you guys
politics.
put a couple of things in there. I will put the link to my YouTube channel. I do a lot of like quick short videos. Hopefully some of you will subscribe. So what I do is, and there's, you're not paying for anything. There's no subscription or anything. I want people to subscribe just so that it actually stimulates how YouTube sees it, and it'll prioritize the account more. So I'm just gonna give you a link. Like, for example, I just put in a video a couple of days ago on the NAD, which is quite a
I love
new,
NAD. I take
yeah.
that myself.
Right. So I put the video like how to do it at home, because we no longer recommend any oral analogs, because not once we start doing injectable, we're seeing such a dramatic shift with a lot of people. It's just better. Um, but I don't want to talk about that. I'm just saying that I think this may be the video for the NAD since you asked, but let me give you just a general link to a channel.
And what is NAD for those who don't know?
It's a energy molecule that we make, our body constantly makes, and it's yeah, and it's basically you can take it exogenously if you're continuously fatigued. But if
Great.
if you're, or if you just want to have more energy in your life for any reason, and also quite often, NAD is just low. Patients who have chronic illnesses, particularly after a certain age, or if it's just an anti-aging thing. So a lot of people nowadays take NAD or NAD precursors because there's decent data that's prolongs life, theoretically, at least now, whether it's true or not. No randomized trials, for full disclaimer. You
All
guys
right. Well,
always been awesome as last time, I remember. I know I can stay here forever, but it's getting late, and I hope everybody have a good rest of the night and start the weekend fresh, and we'll see you soon.
all
Thank you,
right.
Dr.
Thank you so
Kogan.
much.
Thank
We
you.
really appreciate everything.